I will present you a case report. First of all, Neuromyelitis optica is a rare disease associated with the development of antibodies to the central nervous system. Long segments, spinal cord lamination and inflammation, it means myelitis, severe optic nerve involvement and/or persistent vomiting and hiccups because of ARIA post-trauma syndrome are the clinical forms that are important of the disease. And 20 to 30% of the patients with NMOSD, Neuromyelitis optica spectrum disorder, have a coexisting organ-specific or systemic autoimmune diseases. Our case report is a 31-year-old right-handed female patient and was admitted with complaints of double vision, diplopia, severe nausea and vomiting, balance difficulties, dizziness, fever, and widespread aches. In her history, within a month, she was hospitalized with the diagnosis of posterior system-related stroke due to diffusion restriction in the left thalamic and right bulbus, and was discharged with anti-grant treatment. However, her symptoms aggravated after discharging. On admission, her neurological examination revealed bilateral ptosis, prominent on the left eye, outward deviation in the right eye, conjugate gaze paralysis, and bilateral horizontal nystagmus, with the face files to the direction of the gaze. And her speech was dysarthric. Elevation of the uvula was the bilaterally decreased. She reported hypoesthesia in the V3 sensory area of the face on the right side. Motor examination was normal. In cerebellar examination, there was left-sided ataxia with positive Romberg sign. In her blood examination, there were sodium, chlorine, and potassium levels were low. TSH level was high, and low leukocyte with low lymphocytes, hypochromic microcystic anemia, and her autoantibody examinations, there were multiple positivity. There was antinuclear antibody ANA was 4 positive, anti-DS DNA was 2 positive, and anti-histone antibody was 2 positive. Anti-acetylcholine receptor antibody was positive with high titer. In her cerebrospinal fluid examinations, the opening pressure was high. The appearance was clear, but there were 120 cells per cubic millimeter, and her cerebrospinal fluid in protein level was also high, and also her anti-leucoporin 4 IgG anticore level was positive in serum, and her neuroimaging in brain MRI revealed a T2 hypertense lesion extending from the medulla oblongata to the posterior part of the pons, and erythamatosis, minimal enlargement in the brain stem. The presence of parenchymal enhancements in the anterior part of the medulla and superiorly at the pontomedullary junction level in the brainstem. In the post-contrast image, we see it. And also we did computed tomography, angiography, and diagnostic selective angiography because of, they said her it's a stroke, but it wasn't. And also they were normal. And we found minimal effusion, right hemithorax, but there was no thymoma. You know, we said her acetylcholine receptor antibody was positive. And also in the cervical MRI, in cervical 5 to 7 level, in the cervical cord was T2W hyperintense image and minimally enhanced on post-contrast image. In thoracic MRI, there was also T7 to 11 levels T2 hyperintense image. And because of this, we diagnosed her systemic lupus erythematosis, Myastenia gravis, Neuromyelitis optica spectrum disorder. And we planned her treatment. First of all, past steroids we gave to her, and actually her symptoms getting worse, and we get to the plasmapheresis treatment, and it was useful for her. And after that, we continue with oral steroid treatment, and after for prophylaxis, we treat her with rituximab, and prognosis on follow-up with rituximab prophylaxis on the third year now, and she is clinically and radiologically stable now. In this report, a female patient with a history of Hashimato thyroiditis, whose neurological findings were found to be compatible with NMOSD, Myastenia gravis, and who was also diagnosed with lupus, during differential diagnosis, is presented literature about this form of polyautoimmunity, and we say it's multiple autoimmune syndrome, is limited to case reports. Recently, this extraordinary form of polyautoimmunity has been receiving attention from both neurologists and rheumatologists. The frequency of autoimmune diseases in patients with NMOSD is estimated to be 27%. It's not rare. So in NMOSD, we should think there can be another autoimmune disease, and we shouldn't miss them. In NMOSD, first-line therapy consists of intravenous immunoglobulin, high-dose corticosteroids, and plasmapheresis. Early and effective treatment is important on the prognosis. And in conclusion, patients diagnosed with NMOSD may have more than one immune-mediated disorder at the same time. Therefore, in the diagnosis and treatment process of patients with NMOSD, it should be kept in mind that in addition to systemic autoimmune diseases, another neurological autoimmune diseases such as Myastenia gravis may also be present. Aggressive treatment plan and management is important on the prognosis of these cases, which require a multidisciplinary approach. Thank you very much.